So multiple myeloma, it is a tumor of bone marrow. Bone marrow causes proliferation of B cells. So in case of tumor of bone marrow, there will be uncontrolled proliferation of B cells. So this monoclonal plasma cells, nothing but B cells, increase in the number. What happens here is only one type of immunoglobulins are increasing in the number. Monoclonal plasma cells, only one type of immunoglobulins are increasing, rest all decreasing. So obviously the person's immunity will be affected, leading to the recurrent infections. As only one particular type of immunoglobulin is increasing, rest all immunoglobulins are decreasing, the person is more susceptible to recurrent infection. As it is a neoplasm of plasma cells, these plasma cells also infiltrate the bone marrow, leading to reduction in the number of RBCs, causing anemia, WBCs. Reduction can cause again infections. So platelets reduction can cause thrombocytopenia. And in response to that, our body releases acute inflammatory reactants like interleukin-1, interleukin-6, TNF-alpha, which stimulates rank ligand, which causes osteoclastic activity. So always remember, osteoclastic means it cuts the bone. Osteoblastic means it builds the bone. Osteoclastic activity causing osteolytic lesions. The classic term used in case of multiple myeloma is punched out lesions on the skull or raindrop appearance of the skull. As the plasma cells are increasing in the number, they also appear in the urine. So first point, they will be seen in the urine as benzone proteinuria. And second point, when you do the urine electrophoresis, you can see this lambda light chains. And third thing, obstructive cast. There will be cast formation in the kidney, leading to the nephropathy. And this also proteinuria can cause this AL type of amyloidosis. 3 points you have to remember in case of kidney. 1, in the urine, you will see this PJ proteins. And if you do the electrophoresis of this urine, you can see this lambda light chains. And third point is about kidney, cast nephropathy, and also AL type of amyloidosis. So this is the summary of what we are going to talk about in multiple myeloma. Now actually let's talk about the topic. So coming to etiology, males are most commonly affected than females, and classic age of presentation will be 50 to 60 years of age. Radiation and petroleum exposure is a predisposing conditions for this multiple myeloma, and also there is often associated with translocation of 11 to 14 or 4 to 14, deletion of 13q. Coming to the pathogenesis, so what is happening here, this plasma cell is mixing with some other things. Right? What are the other things? One is a plasma cell. Second is the extracellular proteins. 2, it mixes with stromal cells from the bone marrow. Plasma cells along with the extracellular proteins along with the stromal cells, we are there together, and it causes signaling of some acute inflammatory reaction. In response to that, our body releases interleukin-1, interleukin-6 and TNF-alpha. So I have asked you to remember interleukin-6, which is very important for the survival of this tumor cells. Proliferation, it favors the proliferation and the survival of tumor cells. And the other two, and also many other things are involved in that. So this TNF-alpha, interleukin-1 and other interleukins, this causes rank ligand stimulation. So this rank ligand, as we all know, it causes osteoclastic activity. What is clastic activity? It cuts the bone, causing lytic lesions, again termed as punched out lesions on the skull or raindrop appearance of the skull or pepper pot skull. So it most commonly affects axial skeleton. So this is about pathogenesis. Coming to the clinical features, what is happening here? There will be lytic lesions. Because of the lytic lesion, bone is getting chopped off. Obviously there will be bone pain. It gets aggravated on moving, and there will be anemia because the bone marrow infiltration with the plasma cells, leading to normocytic normochromic anemia, which causes fatigue, pallor and lethargy. And also there will be leukopenia, which causes recurrent infections, and also thrombocytopenia, which can cause petechiae. And again, the next point is osteoclastic lesions, which are also known as lytic lesions. These appear as punched out lesions, raindrop lesions, or the pepper pot skull. The important point you must remember is Rolex formation. Number of IgG floating around in the blood. So this RBC is also mixed up with the IgG. It makes the RBCs heavy and sticky. So it sticks with the other RBCs. So what happens in the Rolex formation? The blood doesn't move as fast as normal blood. This hyperviscous blood doesn't move as fast as normal blood, leading to oxygen deprivation, causing headache, blurred vision and many other symptoms. In the kidney, you have to remember 3 points. One is in the urine, you can see this benzone proteinuria. Benzone proteins get precipitated in the distal convoluted tubule. The second point is cast nephropathy. Third point, because of this proteins, abnormal proteins floating around in the organ, you can see AL type of amyloidosis. So these are the 3 main points you have to remember in the kidney. Write it in the exam, you'll get the full marks. Trust me. Right, these neurologic symptoms may also be present later in this condition. Now, lab diagnosis. First, we'll do the serum electrophoresis. You can see this M spike or M band. This serum electrophoresis is based on charge-based separation. You can see this M spike. Now coming to the second thing, which is urine electrophoresis, you can see this lambda light chains. This lambda light chains mixes with TAM Horsfall proteins, leading to obstructive cast. which causes cast nephropathy. Urine analysis, you can see this benzone proteinuria. And one point you have to remember with respect to benzone proteins is the thermal stability of benzone proteins. So what is happening here? When you heat it or cool it, from the temperature 45 degrees to 60 degrees, this benzone proteins get precipitated. So above 60 degrees, no precipitation, below 45 degrees, no precipitation, but in between 45 degrees to 60 degrees, these benzone proteins are precipitated. And also elevated calcium levels can be seen. And if you do the bone marrow aspiration from the pelvis, you can see bone marrow plasma cytosis. That means plasma cells are increasing in the marrow, greater than 10%. Tumor markers in case of multiple myeloma is IgG, benzone proteins, and gamma electrophoresis. Coming to the gross, osseous lesions or the lytic lesions, which are 1 to 2 cm sized defects with osteoporosis. And also this tumor starts in the medulla and extends to the cortex. So this normal bone marrow is replaced by round lesions filled with reddish material. See, I want you to imagine a vertebral bone. This vertebral bone, it has many red color circles. So what is happening here? The normal bone marrow of this vertebral bone is getting replaced by reddish material filled in a round lesion, which indicates the foci of myeloma. Peripheral sphere, which is very important. So this lymphoid cells have eccentrically located cartwheel nucleus. So this lymphoid cells have eccentrically placed cartwheel shaped nucleus. And obviously you can see this plasma cells increasing in the number. So you can see this cartwheel shaped nucleus in the bone marrow. And you can also see this normocytic normochromic anemia because of bone marrow infiltration, which reduces the hemoglobin. And also Rolex formation can be seen because RBC fuses with the immunoglobulin G, which makes it RBC heavy and sticky. So, and also you can see this leukopenia and thrombocytopenia. And in the later stages, right, really later stages, when the plasma cells are increasing like anything, they can also appear in the peripheral smear. And increased ESR can be seen. The specific Russell bodies are seen in case of multiple myeloma. I have made another video on Russell bodies, please check it out. So you'll get all information related to Russell bodies in that video, and it is very important for the VSAQ or the MCQs. So Russell bodies, Toucher bodies, and the flame cells can also be seen in peripheral smear. So these are the lytic lesions. This is a pepper pot skull, or also known as punched out lesions or raindrop appearance. So this is a bone marrow aspirate in case of myeloma. You can see this plasma cells with eccentrically placed nucleus and decrease in the RBC leading to anemia. You can see this normocytic normochromic anemia, and also very less WBCs. So this is about multiple myeloma. And do not forget about Russell bodies, it is important. I have not mentioned here, but please check out the other video about Russell bodies. Bye.